We have plenty of questions actually for this group, so we might as well launch into it. Our first question, gentlemen, thank you.
I'll throw this question to Gary and Dr. Gerber. I see a lot of diabetics and obese, a ton of them. And on top of the markers that I order, like what you order, I add uric acid. A study from Dr. Lustig at University of California, a lot of diabetics, he studied teenage obese kids. He found a lot of people without uric acid, which correlates well with what I've been doing. He treated them with allopurinol, and their blood pressure went down. Do you advocate adding allopurinol together with the LCHF diet on these patients?
I don't know anything about uric acid lowering blood pressure, but you can consider uric acid as an inflammatory marker. There's so many other biomarkers I could put on there. Like you can measure iron, ferritin, GGT. The list just goes on. And I guess as a clinician, you just pick whichever inflammatory marker that you're most comfortable with.
Because the current recommendation in uric acid is that you don't treat unless there is a gouty symptom. So a symptomatic hyperuricemia, according to my other colleagues, is you don't usually leave them alone. But for me, the symptom of hyperuricemia is hypertension, especially among diabetics. So would it help if you add allopurinol in the mix while they go on an LCHF?
That's fascinating.
I've drawn a lot of this information from a fellow in Australia, Professor Ken Sakaris. He's a clinical pathologist. In Australia, we've actually lowered the blood level of acceptable for the upper limit of uric acid. And Ken's thoughts are effectively that if you left it at where it used to be, then half the population would be hyperuricemic. And a bit like vitamin D levels being very low, is that normal? The blood manifestation level of uric acid is actually fairly inaccurate in comparing it to the tissue level of uric acid. So in fact, we measure uric acid, but it's actually a poor marker. It's not a really good indicator of the problem. I'm a great believer that uric acid is central to the whole blood supply to the brain and maintaining blood pressure and hypertension. I keep thinking, why on earth start a drug called allopurinol, which there was a worldwide shortage of it last year, by the way, when you can actually reduce that whole uric acid situation by diet. Uric acid is a poor marker. It's measured, but for jumping towards a medication, that's exactly what I'm not about. Let's get away from the medication. Let's deprescribe, and that's my thoughts about it. But uric acid clearly has a role, central role, in that whole homeostasis, but is actually measured poorly.
Just our next question.
Okay, I'm Debbie Miles, and I'm a ski patroller, backcountry skier, and I have been teaching people nutrition in the backcountry. Yes, it has changed recently. But one of the wives' tales, and this is for Dr. Bikman, one of the wives' tales that works is that if you're in the backcountry, you've been eating your appropriate amount of carbs and going in, and suddenly we kind of stop for about lunch usually, and people are cold. They're not wet, they're not unclothed or anything like this, but they're cold. So what you do is you hand them about a 1-inch piece of sausage, real sausage, mostly fat, a little bit of protein. This has worked every time it's tried. In 5 to 10 minutes, that person is warm. I've had people on the standard diet look at me and say, but you're handing me this cholesterol, but they eat it anyway because they're cold. But it always has worked. It's worked also, the Swiss Army looks at that. They always have a sausage in their packet. But 5 to 10 minutes is not an appropriate amount of time for fat to get into the body. And everybody looks at me and says, it's a wives' tale, it works, but why? And I'm hoping you have the why.
I probably do. So first of all, any meal you eat, there's something called a thermic effective food. And that's very well known here, I'm sure. But however, the consumption of fat, when fat is sensed in the small intestine, it induces the secretion of a hormone called cholecystokinin. And among its many things, cholecystokinin activates brown adipose tissue. That happens in real time. We see that happen in mammals. Thus, it's perhaps the truth behind the wives' tale that the lipid content from that sausage is activating the release of CCK, which is stimulating the activation of existing brown fat, thus creating thermogenesis from circulating glucose.
That's not at 5 minutes. It's at half an hour, isn't it?
CCK, I don't know the timing. I'm sorry, I'm not sure.
Time to get food into the...
Yeah, how long would it take to get to the small? Yeah, I'm not sure. I don't know how quickly it could act. That might not be the best answer.
It seems to be a 5 to 10 minute. You set them down for 5 to 10 minutes, and then they start getting warm.
Yeah, I'm not sure. Maybe the lipid sensing starting from the stomach itself, Gary, to address your point, but I don't know. That's the only mechanism I could think of.
It's better than any one I've had.
Yeah, so let's just take it to the bank.
So now I'm low carb. I am a low carb, high fat, and I hike in with this little tiny pile of food, which is 2 days worth of food for me. And everybody's looking at me as, how can you survive on that little amount of food?
Yeah. So the moral is it's good to have a sausage in the pocket.
On that note, next question, please.
Can I ask him about sausages? Well, this is relevant to the day-to-day thing. I want to talk about urine. Not to take the piss out of you. People measure their ketone levels, and you can either measure it by blood or urine or breath analysis. One of the things that's ongoing is that once you've been running keto for a while, it's talked about that your urinary level of ketones diminishes to nothing. So you might be thinking you're actually doing badly, but in fact you're doing well. And I've been told that that's predominantly because you're starting to reabsorb your ketones. But in your talk today, you were really talking about that you're still... Is there an actual reabsorption of ketones through the kidneys and less excretion over time, or are we just utilising those ketones better and therefore excreting less?
That's it. So I can speculate, right? So
It's in the bank.
yeah, no, not this one, not this. So I'll speculate. I would be shocked if there wasn't a mechanism in the renal tubule to reabsorb a ketone. I'd be very surprised. The fact that we have mechanisms to reabsorb glucose, which is a much bigger carbon molecule than the ketone, I would be very surprised if we didn't. I've heard that as well. Now, mind you, I'm an insulin guy, so I'm somewhat new to the ketone world. But even I've also heard that reabsorption increases. It would make sense. Again, I presented the idea of wasting as if it were, and I didn't intend to, but a takeaway is that, wow, wasting is really neat. It's good. Yet I hope you could also see that means the system is, in fact, inefficient. We don't want to waste energy, and ketones are energy. It's good in this environment when we have an excess of energy as it is. But to me, it would make sense for survival to not let that go. Although the flip side of it is, if we're keeping too much, we begin to run the risk of acidosis. And it's interesting that the kidneys are also the primary place for reabsorbing, just for acid-base balancing, with the reabsorbing of bicarbonate, which is the key buffer in the blood, for producing ammonium from ammonia to buffer high. Anyway, if we're bringing in too many ketones, we would certainly need to make sure we have a buffer system in place. And the kidneys are doing that as well, mind you. But it doesn't make sense to waste energy, except in this environment that we have nowadays in this world.
Okay, we might move on to the next question.
So I just want to thank everyone for your life work. It's just been, I'm one of the huddled masses that is benefiting. But mine is just more of a suggestion to Mr. Martinez or anyone that's out there trying to change political systems. And I would just, it's a strategy maybe you could utilize, especially considering our current administration. I think some world leader is going to be remembered as the guy or the woman who changed humanity, right? It's going to end up like Ansel Keys gets blamed for all of this. Some political president is going to, that carrot, to say, be the change, might be an avenue for you to take to
Well, something
Mr.
very
Trump.
something very interesting about President Trump's family. Ivanka is a low carber.
Wow.
Yeah, baby.
So,
Awesome.
yeah, and so I'm sure that there's a level of awareness there, but this is something to be explored.
Yeah.
President Trump is our president, and so the administration is the administration. We have to work with the leadership that we have, and in these areas, you know, that's why some people have come to me and say, "Oh, we got to do this and got to fight." We have to pick our battles, and we have to think strategically on this. And I think we also have to create an environment where, because people who are on the other side of this, they're really backed up. There's a fear, there's anger, there's uncertainty. We have to create, say, listen, it's okay. People make mistakes. Let's solve the problem. We have to address the diabetes and obesity crisis in this country. We can't afford, we're going to run out of money, and people are getting sicker and dying. And let's, you know, we have to always appeal to, in a debate, I always try to speak to logic and rational thinking. And that, whatever people's emotions are very, very high on these issues. But we always speak to the logic and reason and use of the science. We're just speaking, we want to follow the science and the evidence wherever it takes us. We're not trying to say that this is the be-all and end-all, but for goodness sakes, we can't ignore this anymore.
Great. Thank you. We have another question here.
Thank you. This question's for Dr. Bikman, or for the Diet Doctor, or for the Denver Doctor, whoever wants to answer it. I've been ketogenic for 5 years, and I am an ultra-endurance athlete, and I have been using exogenous ketones for my training, and have really enjoyed those. I also have a practice in Utah where we treat metabolically sick individuals that have diabetes and obesity. And especially the last year or so, they've been coming to me about these exogenous ketones in a practice for reducing diabetes and for obesity. I just can't get my head around the usage of exogenous ketones in that platform, and just want to know what your opinion is on that, and maybe how it affects insulin. And Dr. Bikman talked about supplements, maybe having insulin too high with ketones too high. I'm seeking for truth, and I want some answers, and hope you guys can help me.
Well, I can give you my opinion at least. I think the use of exogenous ketones is mostly for, you know, mental performance, physical performance, that sort of thing, maybe feeling sharper in some situations and so on. I do not think they're really helpful in reversing diabetes or treating obesity at all.
That's my opinion too. Just not sure if I was right or not.
I agree 100% with what he said. I think we have to contextualize it. And if you're a keto-adapted athlete, it makes all the sense in the world. I confess, though, that I grimace when I see the average person who's going for weight loss drinking, or however they actually are consumed, I don't know anything about them, consuming ketones. That is not, we're not built for, I mean, we can handle it. It gets absorbed, which is probably the same mechanism we absorb it in the kidneys, mind you. It gets from the gut into the blood, but in nature, this is not normal. We don't eat ketones. But again, I hate to poo-poo an industry that's just being born, but I can imagine when Dr. Eades showed his slide, you'll remember he showed acetyl-CoA at a branch point of a result of a lot of things and can become a lot of things. I imagine someone drinking their ketones, taking a bite of their bagel, and thinking that ketones are helping. But in reality, we've created a supremely artificial scenario where both ketones and insulin are high. And some of those ketones, as they get converted to acetyl-CoA, will go to the liver. Now you have a lot of acetyl-CoA accumulating and a lot of insulin because of the starch, the glucose from the bagel. And what is the liver going to do with acetyl-CoA if insulin's high? It will turn it to fat. Whether that's happening in the person, I don't know. It's a speculation. But the biochemistry would suggest we're not built to have high insulin and high ketones. So I would just worry that someone may be abusing it and thinking that drinking this is offsetting that, and that wouldn't be the case.
There may be a role of using slow starches and amino acids. I just don't want people to have the impression that if you're keto adapted, that's all you need to do. You just eat keto, you know, you have exogenous ketones. I'm wondering if you're doing anything else besides that.
I'm a very aggressive, low carb, high fat, and I use them just for my long 100-mile runs, 50-mile runs, just to give me a little bit of a boost. It seems to help. I don't know really the science behind it, but it seems to have helped me in that performance. But I don't use them at all in my clinic.
And I just want to add, there are actually carb-adapted athletes that can compete. So it's not for everybody to be a keto-adapted athlete. Tim Noakes even points that out. But long term, when it comes to health issues and you're an endurance and performance athlete, you're probably better off being on the keto adaptation side if you're at all interested about long-term health.
It's changed my life, so it's been awesome. Thank you, guys.
But it does shift the interest. Just in 10 seconds, so much of the benefit of low carb, high fat is lowering insulin. And the ketones are nice too, and they do good things, which is why we're drinking them. But if we're advocating ketone supplements, I fear that sometimes we're not talking about what I believe is the more relevant benefit, which is improving insulin sensitivity and lowering insulin.
Hi. First, I want to thank all the presenters for very informative presentations this morning. I wanted to specifically talk to Peter, a comment on Peter's presentation, and then another comment touching on really all of them, but Andreas's and Antonio's. First, as a husband and a global citizen and a father of a young child, I think Peter's presentation is something that we have to be mindful of as a community, that ecology and environmental impacts of agriculture are important to, or should be important to everyone on the planet. And that we don't have to shy away from that. We just, much like the nutrition science, we present good, sound, ecological science. So thank you very much. We should embrace that, and thank you, Peter.
You're welcome. Thank you.
And then the other comment, and it was so interesting, where we were talking yesterday about how to move LCH forward in these interest groups. And then Andreas's presentation, I think, had one key point, and I haven't heard people talk explicitly about it, and it's the C word. And that C word is that everyone in here is a consumer. And so what Andreas pointed out in his presentation was the butter shortage. And that was driven by consumer demand. So much like you become a fat burner by consuming fat, we can create a real food, global food economy by all becoming real food consumers. So probably the biggest interest group, yes, the life insurance, but probably the very biggest interest group is all of us. Consumer demand is going to be one of the biggest driving forces, I think, in a changed food production system. So just your thoughts on that.
Yeah, I think that's very true. And I also think that when we're talking about change from the sort of political level, I think you need support from people to do that, for politicians to dare to do that. So I think it needs to be a grassroots movement to have any chance of getting, well, the dietary guidelines changed anytime soon, at least.
I would also add that understand that Washington, or government and government relations, things, that it operates, it's a playing field, an arena of competing interests. And so it's important that we all have to come together, the grassroots community, to create an interest that is Congress only cares about two things: votes and money. Any elected official cares about only those two things. Where is he going to get his votes to win his election, and will he have or she have the resources to win that election? And that is why it's critical. I would say that we're not just consumers here, but I would suggest that we are actually stakeholders in this because of our own personal experiences, and also for the professionals and the people that make products, you have business interests here. So it's important to come together and, of course, drive that message home. And it's great that the demand for butter has gone up. So that's going to get politicians who represent dairy interests in the Dairy Council to start rethinking. And in fact, they're going to be more than happy to meet with us and talk about how we can work together, because they're interested in selling more of their product. And we want to make sure that they're selling the best quality product and that their product fits into a pro-health model that we know works for a specific set of the population, which is substantial. here in the United States and around the world.
Pete, did you want to add to that? Peter?
I had an example recently at farm, ag audience, dairymen, and I shamelessly leveraged from dietdoctor.com with Snagit and grabbed those graphs showing the trend in butter consumption and then the change in weight. And I had one of the gentlemen at the end of, and it was 2 minutes or something, and this was about, breeding better grasses for increased fiber digestion. Ooh. And at the end, the first question was, could we have you stop in every city between here and Oregon and give that butter message? Right, so yeah, to your point, yes. To your point, yes. I mean, this is why we each need to work wherever we are, in whatever way we feel comfortable and equipped to do it, to get this message out further, because we've got about 40 years of blowback on us to overcome.
Okay, we might move on to the next question.
First of all, thank you all. Another wonderful morning of talks. My question is for Mr. Martinez. In the light of all the dietary guidelines and the diabetics and the Heart Association guidelines we've had, how much of the resistance to changing it is due to fear of litigation?
There is probably a fear of that because, again, here in the United States, when there's liability laws, and there's always in the back of the mind of an entity that may have given wrong information that, well, what's going to happen? How am I going to get sued? How much is this going to cost? And so forth. We have to evaluate, again, how are we going to hold, how do we hold entities accountable? Because if we destroy the other party, there's an argument to be made that, listen, people that work in public health or in public service or in the public interest were doing it they meant well. They didn't know. They operated with what they were told. Everybody bought Ansel Keys' story. Does that make them bad because of that? That they embraced that and then they repeated it and implemented in policy? These are the challenges that they have to look at. Are we going to bankrupt them for that wrong information? That's the debate. I think we have to engage them to say, listen, you made a mistake and we've got this problem here. Be part of the solution. And let's work together on this. But again, human nature, hey, we're always up against, we don't want to admit error, and we hate to be embarrassed or that we were wrong. Hubris and arrogance is the enemy.
I was just going to say that, but in light of like Nina Teshol's book and Gary Tobes' research, they did know these things and they just suppressed it. And so obviously the current people don't, and maybe they can say, oh, it wasn't me. I've just wondered whether a lot of the resistance may be due if someone who's just had their leg amputated and said, well, hang on a minute, I've done everything I've said, I've got this, and
It's going to have to be sort of the best way I can describe it as a good cop, bad cop, where there's a reaching out in a constructive way, and then in another way, which is a battle to say, hey, and I acknowledge that yes, the sugar industry knew, and they gamed the system with those Harvard studies, and Gary Tubbs speaks very clearly about that and lays out the case quite convincingly and persuasively with real evidence. And yes, you have to ask, should there be accountability? And yes, I agree, but we have to think about solving the problem of what we're dealing with right now, the diabetes crisis.
Thank you.
I might just throw my example in there, which was pretty well underneath the radar until we went public. And then a lot more people know about it. And maybe there needs to be a class action against an institution. And I know that there are some large diabetic groups in the world who are considering that. To set an example, make it as a turning point. and I'm no lawyer, but I'm wondering if, certainly in Australia, my case has all of a sudden brought a whole lot of things to the fore.
Certainly has.
And maybe I've taken one for the team, but maybe the same thing needs to happen in the US. And whether or not it's against big pharma or against big food or agribusiness, I don't know. But someone's head, I think, needs to go on the block once.
Thank you.
Say something about the American Diabetes Association takes the formal position that they don't advocate any particular diet. Yet at the same time, the recommendation about consuming 130 grams of carbohydrate, it's astounding. And they are not going to be able to ignore this any longer. I think we're reaching a point of a critical mass, and they're going to have to respond.
I think the dietary guidelines for American is guidelines for healthy people, but when those guidelines are making people sick, it doesn't seem to make sense.
Right.
Yeah. Okay, we might move on. Dr. Eads, your question, please.
I'm going to do that which I hate at these things, using a Q&A for a statement. I was going to do this last night because of Ivor's talk, but it turned out to be the Ron Rosedale show on the comments because of his provocative talk. And a lot of people have asked me about that, what I thought about that, and I always say, caveat emptor. AMPK is a signaling enzyme that's upstream of mTOR, and we know that AMPK is stimulated by a low-carb diet, so it should suppress mTOR. But anyway, my statement, Jeff gave me an opening because he mentioned calcium scoring. And I like calcium scoring because it's the only way that you can really visualize the problem. All these other things are just markers, and oftentimes they have no correlation with what's actually going on. But with calcium score, you can actually see it. And what you find sometimes on people on low-carb diets is their calcium scores get worse. And you know that they're getting more healthy, and you wonder why. And I've seen this. And what happens in calcium scoring, which is a great diagnostic tool, but what happens in calcium scoring is the density is measured in these units called Hounsfields. But anyway, it's measured, and a lot more emphasis put on the density than on the volume, because the volume of the plaque is also calculated. And what happens is the bigger the plaque volume, it's generally the more unstable the plaque is, whereas the smaller the plaque volume, the more stable it is. So you can actually, there's a system, anybody in here had a calcium score? That you've had looked at? I mean, you've got the document for it. If you go in and take the volume, it'll say on there whether it's a 2.5 millimeter slice or a 3 millimeter slice. Divide the volume by the millimeter sliced, and then divide your score by that. And if your score is 1, you really have 0 risk, even though you've got a calcium score. Okay? And it'll be anywhere from 1 to 4. And if it's 4, you got a lot of risk. If it's 1, you've got essentially 0 risk, even if you've got a high calcium score. So anyway, that was...
Yeah, Mike, Ivor, and I have spent much time talking about this. And if you noted, Ivor mentioned David Bobbitt's calcium score. So his density went up, but his volume went down. And so I think as volume as areas, it's a 3D image. Jeff Pedley, who's an engineer, actually takes his raw calcium data and he calculates his score. He's he works with satellite pictures. It's the same kind of thing. And so the volume score is looking at new areas, okay? Where the density looks at existing areas and how much calcium is in there. And there's some argument that an increasing density is stabilizing, whereas increasing volume means that there's more plaque burden. Mike's agreeing.
Next question, please.
Yeah, hi. I have a degree in MOM. That means I'm a mom of a type 1 diabetic, and that's what brought us here to the Low Carb Convention. I am thrilled to be here. You guys, I appreciate everything you've said. My question is a grassroots question because that's basically where I'm at. My question, I have a statement first, and I took on my her endocrinologist, I should say, as they watch her A1C drop after 10 years of having a high A1C, following the guidelines that they gave us, being up all night with high blood sugars. And I finally we got it down, and it's been steadily down, and we're happy with it. And after they congratulated us, they told me to add carbohydrates to her diet. So after a 2-hour conversation, we agreed to not discuss carbohydrates anymore. So I took that on. My next problem is other parents of type 1s. See, I know I'm very active in the type 1 community in my area, and they see her A1C dropping. They saw that I have lost weight. They see my husband losing weight. They see how we're, progressing. How are you doing it? I'm getting Facebook messages. I'm getting questions. And my answer, obviously, you know what the answer is. And I get, they're still going to have to take insulin, and I want them to be a normal kid. How would you respond to that? Because it drives me crazy.
Have you heard of a Facebook group called Type 1 Grit?
I love type 1 grit, yes.
Okay, just keep setting the example.
Okay, but like I'm talking about even my local, and I'm a part of that, and that's like, I'm assuming worldwide is type 1. I'm talking about friends that I see on a basis that I've made friends with and my daughter has made friends with in our community. You know what I mean? So like the type 1 grit is almost, which I love and appreciate, a different sect of my friends, because I have real life friends that I see weekly that are arguing. You know what I'm saying? Like, so I'm trying to figure out how would you respond to them?
Keep setting the example. I mean, it's
That's
whether
it.
or not you're doing it for yourself, for your children. I mean, that was a constant question we've had. Oh, my children won't do it. That's okay. Just you keep doing it, and ultimately they'll come around. All of our children have done it. If they're arguing about it, you're starting to win.
Okay. And I mean, the argument to me is it's not normal childhood, and I do the same thing. I'm putting these pictures up, and food, like, are you kidding me? She eats better than any person I know. You know what I mean? Like, our food is wonderful. So
You're winning. Yeah.
It's the current normal childhood.
right. So okay, but thank
Congratulations. Welcome on board.
But thank you.
You're doing it. This is what it's about. It's the grassroots. And in a year's time, there'll be one of your other friends who's done it. And then...
I hope.
No, there will. And then in 2 years' time, it'll be 4. It'll be 8. It will happen.
Thank you.
Thank you.
I would just add also, tell them that the risk of your child developing double diabetes is much less than their child, and make it a competition. I mean, the more insulin they're giving their kid, the more resistant to the insulin that child is becoming, and that is a real phenomenon of a type 1 becoming type 2, but yet still type 1, double diabetes. Your kid almost has zero chance of that ever happening. Their kids do, so make it ugly.
Your next question, please.
Well, thank you for everybody. You guys have been great. I have a question primarily for Dr. Gerber. The elephant in the room for the physicians who are here, and there's a lot of them, is how do you stay under the radar, and how do you continue to keep your insurance contracts, take care of your patients, and skirt the standard of care, because we don't believe in the standard of care when it comes to nutrition?
Well, it's an interesting question. We discussed it quite often when I traveled to Australia earlier this year. And it seems that there's a bit more flexibility in the United States in terms of, what we're able to do. Now, on the negative side, we can have quacks working in the system that can get in trouble. So maybe I'm a quack, but we have some we have more freedom, I think, here in the United States. And so if I can show that we're improving comorbidities with whatever counseling that we do with our patients, and the numbers demonstrate a benefit, nobody seems to make a stink. So I've been doing low carb, high fat, recommending it to my patients for 17 years. And my physician colleagues around the hospital where I work, some of them know specifically what I do. Some just know that I help people with metabolic disease and weight issues. And so far, it's all good, knock wood.
We're a Medicaid practice, so we're highly regulated, and so if we get an obese kid, they want you to send them to the nutritionist to, what they say. They have guidelines that if we follow their guidelines, we can't follow our conscience.
So we take Medicare and Medicaid.
Do you?
And again, I guess you could make an argument we don't follow their guidelines, but if we can demonstrate that the outcomes are favorable, how can they?
Have you been questioned on it?
No. So again, my goal is an important goal, and Mark Cucuzella left as well. He's another family doctor, and we very much want to work in the system and to change the system and to work with guys like Tony, right?
I mean, I would say to you for the, if you have patients, your practice is Medicaid?
It's
Patient?
Medicaid and it's pediatric. And
Okay, so there's two routes that I would suggest in that case. I would talk to the Medicaid people, and I would also talk to your state legislators that manage and decide and tell your governor, and also speak to the governors that how these monies are being spent or these programs. Say, listen, we can do this, and we could be saving so much money. As I told you, New York State, my state, we're like from 2015, our Medicaid diabetes bill was $1.3 billion. And the controller's or the office which issued that report said it's unsustainable. And so when you approach them, we have, and they say, well, we need to meet, we need to sit down, we want to hear about this, bring together your team of experts, and let's listen and hear what you have to, how we can address the problem. So engage the system, engage your elected officials, and tell them, look, we could be, every elected official is looking for a way how they can save money. And if you can tell them, I can show you how we can save money here, they'll listen.
Thank you.
Now we're almost running out of time, so if we could keep this as brief as possible. Your question, please.
Is hair loss a side effect of the low-carb diet? And if so, why? And what any recommendations?
No.
Anytime you lose weight, you lose hair.
Oh, really?
Doesn't matter what the cause is. Let's say give it some time.
And does it
Work
grow
for
back?
me? I've been waiting for 20 years. No, but that is true. You can look at any method of weight loss. If you're losing weight, you're going to be losing hair, and usually it just sort of levels out. But I'm actually a redhead. I have the little boy to prove it. You just wouldn't know.
Thank you.
I think it's not uncommon, but I don't think it happens to everybody.
I don't know.
But anyway, like 3 or 6 months after like a major diet shift or stressful event or all kinds of things really, you can get this situation where all your hair growth sort of synchronize and they fall out at the same time, and then it takes a few months, and then they start growing again, and you get your hair back. It gets temporarily thinner, but that can happen for lots of reasons, lots of diet changes, lots of other things.
Next question.
All right. I'm a PA in Colorado Springs, working in a community health center, mostly Medicaid, Medicare. I heard you mention that just previously. What is the best way to monitor, I guess mostly for Dr. Gerber, but maybe also Antonio here, to monitor those risk factors when Medicaid, Medicare are denying the coverage for these tests, even something as simple as a lipid panel, CRP, the A1C every 3 to 6 months. Any suggestions on that?
I want to interpret from a clinical first, and then I'll...
Yeah. I don't look specifically at our reimbursement. Perhaps I should more closely, but what I hear is we do the 2-hour insulin test, and we've been getting reimbursed for that. So lipid panels. I mean, there's restrictions on how often you can do it, but in general, it seems to be okay. In your experience, are you finding that it's getting kicked back?
Medicare mostly, but even sometimes with Medicaid.
Like what kind of test?
Even something simple as an A1C, I get a report back saying the diagnosis E11.9 doesn't coverage. Do you have anything else? So it doesn't make any sense.
Yeah, it's just, is it an issue of how often? It might be a yearly...
It could be, but it's like 3 to 6 months even.
Yeah.
So
I would formally appeal that, but then I would also alert, you're a member of Congress or your senators, because they're the ones that have oversight over CMS. They're the ones to be able to say who's making these decisions, or why are you doing this? And then they may actually be able to facilitate a meeting where you can make your case, or at least get a clear understanding why they're making why they're making those denials, and then you have to think about, given whatever the parameters that you're operating, what's the best way that you can help your patient within those parameters.
Perfect.
Okay,
Thanks so
speeding
much.
through, please.
Question for Peter regarding regenerative farming techniques, the work of Dr. Alan Savory, things like soil carbon cowboys. Friends who are environmentalists say that this is a over-exaggerated view of what can be done. Where are we at in terms of regenerative farming? Is that really a potential for change in terms of environment and feeding the planet?
Great question, and I would say that these things have been demonstrated in research. There are going to be differences in regions, because in a lower rainfall area you're not going to have the increase, but then again you're not going to have the oxidation of the organic matter. But this is something that's been known and demonstrated in our literature for, again, 30, 40 years. So it's really, in my experience, we're not having a conversation about that. We're having a conversation about something else, but we're talking about that, if you know what I mean. So, we can be very confident in that.
Thank you.
Yeah, I've got Richard from Australia, and I just want to thank everyone for the presentations. A 30-minute presentation on ruminants has no right to be as entertaining as that was. But my question is for Dr. Bikman, and unfortunately I missed the beginning. Yes, please. Yes.
Yeah, my name's been, I've heard clever, Bikman.
Bikman.
But call me Ben.
Yeah, that's okay, thanks, Ben. So my question is that I do have a podcast with a large online community, and our most popular podcast was about fasting. And we've found in our community that there are some people who just cannot fast. And some can do it for like 18 hours until, and then they run out. And it appears to be all of the people who have not a lot of body fat, because they seem to be coming up against a limit of how much or how fast body fat can produce energy for them to use. And we've noticed in that community that, or that group, that heating seems to be one of the optional uses of energy that seems to be a signal that, okay, now we're starting to run out of energy, so now I'm feeling cold. And we find in that group that if they just have a spoonful of butter, that almost within 5 minutes they feel warm again. And I was curious, are we talking about, or is that an observation of an increase in substrate, because there's not a lot of energy coming from a teaspoon of butter, or is that signaling from the gut, do you think?
That's a great question. I'm so fascinated by these now 2 reports of eating fat and warming up. So there's already plenty of lipid in the blood, and then that single tablespoon, boy, or even the piece of the meat, that's not a lot.
In some cases, this is after 2 days of fasting, so the lipids in the blood are now just coming from body fat.
Yeah, and so they're feeling cold, they do this, and they suddenly warm up for some period of time. Well, that is something that quick. Again, at the risk of sounding like a broken record, I can't help but think, I'm aware of that one single mechanism. You ingest fat, the sensation of the fat, and I don't remember where exactly in the gastrointestinal tract from mouth to anus it's happening, but some point very quickly after consuming the fat, you are releasing CCK, which is not increasing the amount, but it is just turning on the switch. It's activating the nerves. CCK tells the brain, turn on those nerves that are innervating the brown adipocytes. And once they turn on, uncoupling happens. That's what they're for. So again, at the risk of sounding like a broken record, that has to be the mechanism. But I'm open-minded because I'm a scientist seeking truth. There could be another one, but that's the only one I can think of.
Okay, thank you.
And it checks the boxes, too.
Okay, Nina.
Okay, thanks. I'll try to be concise. This is a question for Jeffrey. about using scans of ultrasound scans of arteries, because in my research, what I came across is that the amount of plaque in the artery is not a good predictor of heart attack risk, because it turns out that the arteries expand. They can expand to deal with blood flow. And so I'm wondering why you use those scans, if you do think they're meaningful. And the reason I'm asking this question is that Dean Ornish always says, on his study of like 19 people, he's like, I'm the only person who actually measured heart disease. All of you out there, you look at LDL and HDL, and he says, none of that is meaningful. I'm the only one who actually measured heart disease in its actual state because he did ultrasounds.
Are you referring to Dean Ornish was focusing on elasticity?
No, he was focusing on the actual buildup of plaque. So in his studies, he says, you see, there was less plaque buildup on his very low-fat vegetarian diet.
Oh. Yeah, I mean, so many people have debunked his studies.
I'm just talking about, my question is about the use of those scans, and do you think they are meaningful? Do you think that the narrowing of the arteries that you see in ultrasound scans is that meaningful compared to other cardiovascular risk markers, I would say?
Yeah, I think it's a proxy to the calcium score itself. Now, I just have to back up intimate thickness again. The big pharma really likes to use intimate thickness, and here's a catch to that you can have a really thick intima, and you tend to have high cholesterol, and you go on a statin, and the intima shrinks, and it brings your cholesterol down. But again, if you look at studies, does it correlate with risk? And it doesn't seem to correlate. There really isn't good data on looking at the carotid artery itself. So we kind of use it as a rough estimate. In fact, I think last year I met an individual that actually wanted to have a more quantifiable way of relating plaque in the carotid artery to risk.
Mm-hmm.
But we have that kind of data when it comes to calcium scores. And Dean Ornish probably doesn't know anything about calcium scores. The data is been demonstrated in literally hundreds of thousands of individuals, and the risk goes up by orders of magnitude when you compare a 0 calcium score to a high calcium score. And calcium is really plaque. You're seeing the disease, so it correlates as far as what I understand.
Okay, thank you.
Yeah.
Right. For anyone that wants to do Daryl Edwards' fitness class, that's started in the Aspen room at 12:30. But we'll take 2 last questions and then we'll have to end it. So, Dr. Westman?
Yeah, just Dr. Gerber and I are members of the Obesity Medicine Association over the last 10 years in a real medical association, the Obesity Medicine Association. Go check out the website, obesitymedicine.org, and download the algorithm for free. And in a national guideline algorithm, carbohydrate restriction is the technical term for LCHF, for low carb, high fat, for paleo, for keto, for all of these synonyms. And you can use those slides for free to validate what you're doing in the clinic, in the policy arena, in the agronomist. Anyway, so those slides, we've worked on those slides hard. There are other members here in the audience who have worked on them. So please take advantage of it. Go to obesitymedicine.org. Thank you.
I just wanted to make a quick comment about Ornish and stenosis, because at one point I looked into the measurements of stenosis and what the measurement error that people found to be acceptable to make a claim about one measurement being different from another. And I found 3 studies, and one of them recommended that has to be a 15% difference, one 9.3%, and one 7.8%, to show that there's an actual difference in measurements. And Dr. Ornish's studies showed a 2.2% change. And so it's completely not even within the bounds of error of the measurement, as far as I understand.
So that's great, Amber. There's a bit of an art to doing the carotid Doppler test, so you have to take that into consideration. We've been using Sonia, one person from one company for now 3 to 4 years, and we had to get rid of the original company that we couldn't find any consistent results. So it is an art. They were angiograms. Do you want to comment, Mike, real quick? Oh, she was saying angiograms. Well, I can't hear what you said.
He's saying that the reduction in change that Dean Ornish detected is not even within the acceptable limits of claiming that there's a
So
reduction.
Amber just debunked it.
There you go. Thanks. Thanks, Amber. All right, that concludes this Q&A session. We'll break for lunch and we'll return at 2 o'clock. Thank you. Thank you.